Hello and welcome everyone. Today we'll be discussing regarding continuous renal replacement therapy in ICU. The incidence of AKI in ICU ranges from 20 to 50% for all ICU admissions. In these patients, the patients who go on to receive kidney replacement therapy is around 5 to 15%. So continuous renal replacement therapy is a modality which is preferred for hemodynamically unstable patients. Nephrologists and intensivists must be skilled in prescribing, monitoring, and adjusting this therapy. So, what are the indications? Apart from the decisions that you have already seen in your ICU, that is based on solute goals, fluid goals, and metabolic goals, the standard indications for dialysis are similar. So, what are the modalities that are available? The available modalities are the continuous therapy, the prolonged intermittent therapy, and the intermittent therapy. And in very rare cases in ICU, you can also go for peritoneal dialysis. So the main debate is between the prolonged intermittent and the continuous. The prolonged intermittent is a hybrid form with intermediate flows and a time that is around 6 to 18 hours. While the peritoneal dialysis is a viable option in resource limited setting, if there is some lack of storage or vascular access, and but the use of this therapy comparison with continuous therapy is lacking. Now, as we have already discussed, the main confusion is between continuous versus intermittent. So continuous is often the standard of care in hemodynamically stable, but this is not based on any clear-cut studies. So there is no definitive proof to say that this is actually superior in comparison to intermittent or even for that matter prolonged intermittent. There are observational studies, RCTs, and meta-analysis which are largely equivalent outcomes. There have been no differences either in terms of mortality or in terms of kidney recovery. Some trials show better hemodynamic tolerability with continuous therapy. Others did not find any significant difference in hypotension and vasoactive support needs. But the problem lies in actual definition of these things. How do you define hemodynamic tolerability? So these definitions are not standard or uniform or based on any society guidelines. So these are variable from study to study, and to tell that actually what exactly we mean by hemodynamic tolerability or how continuous therapy provides better hemodynamic tolerability for that matter is still a matter of debate. Now, trials are often tailored intermittent to improve the hemodynamic tolerability, which have excluded severe in unstable cases. So, if we remove the severely unstable cases, then also the analysis becomes very biased. So, what are the clinical outcomes and practical advantages? Continuous intermittent and prolonged intermittent have similar outcomes in stable patients. Continuous is superior in preventing and treating volume overload, and it is crucial for patients with cardiac and pulmonary failure who require mechanical circulatory support. So, continuous therapy has an advantage theoretically where you are doing the dialysis mainly for a volume control. Continuous therapy also allows gradual volume removal, reducing the risk of hypotension from ultrafiltration. So, for that matter, a patient on ARDS with shock requiring NORAD support, in that patient taking out fluid, it will be better to do that with continuous rather than intermittent or prolonged intermittent. Now, intermittent can cause net positive fluid balance and require rapid ultrafiltration, increasing the volume overload risk. This is especially during the interdialytic phase. So, what are the preferred patient conditions to undergo continuous kidney replacement? So, patients who are at high risk of harm from volume overload, patients with or at risk of intracranial hypertension, that is, patients who have developed a renal failure following a brain injury, or patients with acute liver failure. CRRT should be avoided for rapid urea clearance, preventing cerebral edema and dialysis disequilibrium syndrome. Now, the nutritional conditions considerations. Continuous therapy has higher daily clearance due to its continuous nature. So, it allows full dose of nutrition without protein, phosphate, or potassium restrictions once the metabolic control has been achieved. So, basically, you have to give this therapy to patients who are having a need for very tight control of their volume status, and those patients who will have problem if this control results in fluctuation. For example, in intermittent therapy there will be fluctuation in the volume status because I can't do the therapy every day or throughout the day. I have to do intermittently. Once you introduce that intermittent, the period where the patient is not on dialysis increases the chance of the volume going up, which can affect, if the patient is for cardiac or respiratory cause, the respiratory parameters, or if the patient is having cerebral problems like brain injury and acute liver failure, the cerebral edema. Now, general indications for this is that it is applied to patients who are hemodynamically unstable and with multi-organ failure. The traditional renal replacement therapy indications do prevail. So, specific conditions for continuous dialysis, apart from these, are severe rhabdomyolysis, tumor lysis syndrome. These are the two conditions where a continuous therapy is specifically used and is considered better in terms of outcome compared to the intermittent therapy. So, preferred conditions where we can use are AKI with acute brain injury, acute liver failure, cardiopulmonary failure requiring ECMO support. Now, it can also be used as a bridge to transplantation. The use of AKI in advanced heart and liver disease in patients awaiting organ transplant, preferred for patients intolerant to intermittent hemodialysis due to low effective circulatory volumes. Therapeutic hypernatremia safely induces a steady state therapeutic hypernatremia to reduce the cerebral edema in AKI with brain injury or liver failure. Managing severe dysnatremias. Now, preferred over intermittent for severe dysnatremias, and it is customizable circuit with sodium concentration preventing rapid corrections in either directions. Slower dialysis mitigates the risk of osmotic demyelination and cerebral edema. The decision factors are must be considered in context to the patient, the non-kidney organ involved, and the specific goals that you want to achieve by introducing a continuous therapy. So you must be very clear, it is not a replacement for intermittent therapy. It is, I must have a specific goal in mind when I am introducing the continuous therapy. So solute clearance methods in the continuous therapy. The first one, that the most commonly used one, is the CVVHD, that is continuous venovenous hemodialysis. It is predominantly diffusive clearance. High flux dialysis allow for convective flow and clears high molecular weight solutes as well. The next is hemofiltration, where there is convection based clearance and the replacement fluid can be administered pre, post, and both as well. Now, 100% of the post filter replacement is most efficient but increases the risk of clot. Pre-filter replacement dilutes the blood, reducing small molecule clearance efficiency but decreases the filter risk. Now, finally, you have the continuous veno-venous hemodiafiltration, where you have both the methods of diffusion as well as convection. So these are the essential three methods that we have. The thing that we need to understand is there is something called filter clotting and filtration fraction. Now, filtration fraction is the proportion of plasma water removed by ultrafiltration, and it is inversely related to your blood flow rate. Most centers use a mix of pre and post replacement fluid to maintain a filtration fraction of 20 to 25%. High flux dialyzers, standard for continuous therapy, theoretically remove substances up to 10K to 40K Daltons. Effective pore size in vivo is smaller due to plasma protein adsorption on hemofilters, making the pores smaller. What type of modality should I use? No convincing evidence that any particular mode, as the three that we have discussed till now, that is hemofiltration, hemodialysis, or hemodiafiltration, any one of them has a better outcome or something. Selection is based on your local practice, your logistics, and obviously your provider's preference. Convection removal of middle-sized molecules, that is cytokines and inflammatory mediator, is hypothesized to be of benefit in sepsis and post-cardiac surgery patients, but clinical trials have shown no benefit as of now. Circuit patency and the modality comparisons studies show longer life with CVV-HD or CVV-HDF over just CVV-H. Now, comparisons limited by heterogeneous study design, variable anticoagulation use, and small sample size, and of course the inconsistent results. So definitive conclusion is still elusive for this particular parameter. So how do you prescribe? The first thing you need to prescribe is the vascular access. So what are the preferred sites? The right IJV is the most preferred. You can also give it to the femoral, left IJV, and subclavian is the last resort and should never be used until and unless you are forced. But if you are forced, do use it. Now, considerations is left IJV is preferred over femoral in obese because there is a more complication with the device if you are using femoral catheter in obese patients. Femoral access is associated with high infection rates. Right IJV has the lowest catheter malfunctioning compared to even the left IJV. Regarding the fistulas, needle cannulation can be used but is not standard due to the risks, and continuous therapy is performed with catheters, which is always better rather than through the needles. So what is the dose that we need to give? First is our access, then you have dose. So what is your objective? Is the urea and solute clearance. Clearance is approximately the effluent flow rate, which is given in milliliter per kg per hour. So the recommended dose as per KDIGO is 20 to 25 ml per kg per hour. To account for the interruptions and efficiency loss, you prescribe 5 higher, that is you go from 25 to 30 ml per kg per hour. Still higher doses temporarily needed for severe or refractory hyperkalemia, acidosis, hyperammonemia, or intoxications. Adjustments: reduce the dose once adequate cellulose control is achieved to avoid excessive nutrient and medication clearance. Now, dose less than 20, higher mortality risk associated with historical data but not confirmed with prospective studies, can be considered if fluid shortages or severe obesity is there, though the data is lacking whether we can or cannot use this. Japanese data suggests that flow as low as 15 is safe, but it is not something which is very widely practiced or recommended. So next consideration is for the obesity, how we manipulate our dosage. Use the actual body weight with a dose cap of 5000 ml per hour. Start with the actual body weight and adjust based on the serial assessments. Use adjusted body weight, that is ideal body weight plus 25% of the difference between the ideal and the actual body weight. Now, as we already have seen, there is a limitation in terms of data that we have. AT and renal tests excluded patients who had a higher body weight, and prospective data on CKD dosing in severe obesity is something which is lacking. Next is the blood flow rate. The blood flow rate is something which you keep at 100 to 300 ml per hour, lower than the intermittent hemodialysis. Clearance primarily is determined by the total effluent rate, that is dialysate, plus the total ultrafiltration rates. Blood flow rate should be at least 2.5 times the dialysate rate in diffusion-based continuous therapy. In the CVVH, the blood flow should be more than 200 to 250 to maximize clearance and to manage the filtration fraction. Studies show no consistent effect of blood flow on circuit lifespan. Higher blood flow rates may cause access and circuit pressure alarms, potentially leading to clotting. Post-filter hematocrit may be a useful metric to assess the risk of clotting of the circuit. Now, finally, the anticoagulation, which is also a very important thing, it requires to prevent the clotting of the circuit. The options are preemptive regional citrate, heparin, or initiating continuous therapy without anticoagulation and adding if clotting occurs. KDIGO guidelines recommend a preemptive use of citrate in patients who do not have a contraindications. COVID-19 may require dual anticoagulation due to high clotting risk. Regional citrate infused prefilters targeting lower intrafilter ionized calcium to prevent the clotting. Intravenous calcium infused post-filter or systematically to prevent hypocalcemia is a must in these patients. It is superior to systemic heparin coagulation by reducing the bleeding complications. It is complex and the risk of metabolic complications are also more. So you must be very, very good in terms of your monitoring, especially the citrate, the calcium, the magnesium, and the sodium. The total calcium by the ionized calcium ratio of more than 2.5 traditionally used to detect citrate accumulation. Elevated lactate is the best predictor of citrate accumulation. Regional citrate can continuously be used in patients with advanced liver disease with close monitoring. Recent data suggest a longer life, that is more than 48 hours, may increase infection risk independent anticoagulation choice. Now, if you are planning for heparin, then it produces a systemic anticoagulation and it is not dialyzable. It is used for regional citrate, is contraindicated, or in a combination in patients who have very high risk of clotting. The clinical consideration are adjust the dose of continuous therapy and anticoagulation based on the patient's hemodynamic risk, the risk factor of clotting and bleeding, and the metabolic needs. Monitoring for metabolic complication and adjusting therapy is crucial for safe and effective continuous renal replacement therapy management. Finally, we come to the ultrafiltration. There is limited data to guide the volume removal prescription. Ultrafiltration is the primarily modifiable risk factor for hypotension during the replacement therapy. Non-modifiable factors are increased vascular permeability, impaired vascular filling, and may mediate hypotension in ICU patients. Some patients may benefit from ongoing net ultrafiltration despite hypotension requiring vasopressor support. Managing the volume status is crucial. It requires integration of the various data points, serial reassessment of the ultrafiltration goals, and the tolerance to increasing the ultrafiltration. A good collaboration between nephrology and critical teams is essential in optimal management. Now, weight-based prescriptions, net ultrafiltration, like total effluent dose, should be prescribed based on the weight, that is ml per kg or per hour. Observational data suggest a U-shaped relationship between the net ultrafiltration rate and mortality, where you have a very narrow margin at which the ultrafiltration mixes properly and you get an optimal volume status. If the ultrafiltration is low, then you will give tissue edema and decreased tissue perfusion, or if the ultrafiltration is more, then the volume goes down, again resulting in tissue edema and multi-organ failure. So optimal ultrafiltration rate, the lowest mortality rate is associated with 1 to 1.75 ml per kg per hour dosages. And the need for interventional studies to validate these targets is very important. Now, next thing that we need to understand are the complications. Now that we have prescribed the dose, the site, the anticoagulation, the blood flow, and the ultrafiltration, now we must be aware of the complications. We have the catheter related complications, which are common with all the types of catheters, which is very common in the ICU. Next is the extracorporeal circuit related complications, again, which most of the people are aware. It is the same for all type of dialysis, ECMO, or anything where you have an external circuit. So apart from this, there will be metabolic disturbances. There is, because of the citrate that we are giving, you will have citrate accumulation toxicity, buffering excess or deficit, calcium changes, sodium changes, magnesium changes, phosphate changes. Now, apart from these, the other complications are hypokalemia, hypocalcemia, hypomagnesemia, hypoglycemia, euglycemic ketoacidosis, inappropriate medication dosing, and inadequate nutrition. Apart from this, the most important one is the hypophosphatemia, which is most commonly missed, and it is common with continuous therapy because phosphate-free solutions are mostly used. It is associated with poor outcome in critically ill because it leads to prolonged mechanical ventilation because poor muscle strength, and can be prevented by proactive phosphate supplementation. Phosphate-containing solutions are formulated without dextrose, potentially requiring additional glucose to prevent hypoglycemia. Now, there are other electrolyte abnormalities as we have already discussed. These are less frequent but should be kept in mind. Hypomagnesemia is again something which is commonly missed. Lack of prospective data to exactly quantify what is the incidence of these complications is a matter of concern. So quality assurance is effective quality assurance program must be there so that once you initiate a program like this, you check whether you are actually providing the care that you want to provide. Local protocol should be there, and continuous monitoring for parameters like citrate, calcium, magnesium, and phosphate every 6 to 12 hourly is essential to prevent complications. So, the nutritional management, the continuous therapy removes the small soluble solutes, including the essential nutrients. So, adequate nutrition is crucial. So, take a higher calorie target, some 25 to 35, and obviously higher protein target up to 2.5. Drug dosing and removal is again very crucial. You must check your antibiotic dosing, especially for continuous therapy. Since there is limited data and the risk of underdosing and overdosing is there, it is better to overdose rather than underdose because your management of the infection is vital. Hemofilter absorption significantly contributes to the drug removal. Ensure appropriate antibiotic dosing and therapeutic drug monitoring. And this is one of the algorithm which will help you in understanding how the CRRT should be initiated in an ICU, a stepwise manner. And first is the indications and the various steps. So you can go through this. Thank you for your patience.